Good morning, respected chairpersons, panelists, and my friend. I've been given the responsibility to talk. It's a very delicate subject in heart failure. As chairperson has already mentioned that it's a in advanced heart failure it is really difficult to optimize the medicine what is supposed to be. So let us see what is heart failure kind of trajectory according to the time. If you really analyze the course of the heart failure, after diagnosis there will be a lot of ups and downs. Even after GDMT therapy, you can see there are significant residual risk in the, as you have seen that the DAPA heart failure is almost a 14% residual risk. So even adequate optimized GDMT therapy in early stage of heart failure, you cannot reduce the kind of risk of further progression or even deterioration of the heart failure. So always the residual risk will be there. If you go further, you will see the worsening of the heart failure. There will be acute exacerbation of the heart failure in between in the course, which is very difficult to manage, what is called worsening of the heart failure. This is one subset of people. Nowadays, maybe there are some new treatments are coming up, probably that can change the trajectory in this worsening heart failure. It can, again, this group of patients can be restabilized with drugs. However, in due course, many of the patients, although there is no significant data how many patients go to advanced heart failure, but some data says that on 1 to 10%, up to 10% of the patient in a heart failure, chronic heart failure, can advance to the advanced heart failure, which is called stage D according to HA. This is the stage where it is very difficult to continue the GDMT because the tolerance will come down. They will develop multi-organ damage in respect to the renal failure. So they become more refractory. So this is the stage probably we need to think about further treatment like a heart transplant or kind of other therapy. So what is advanced heart failure? Traditionally, it is defined as a marked heart failure symptoms that interfere with daily life and with recurrent hospitalization despite attempts to optimize guideline-directed medical therapy. Due to insufficient representation of patients with advanced heart failure in major heart failure trials, the results of these trials cannot be transferred to patients with advanced heart failure. For example, in paradigm heart failure, less than 1% of the patient will advance heart failure. So actually it will not represent the real world scenario. Thus the efficacy and tolerability of GDMT in patients with most advanced stage of heart failure often remains unsettled. This poses, at the same time you know that the number of patients with advanced heart failure increasing due to improvement in the heart failure care. Again, this poses a challenge to treating physician as much as such patients usually experience severe symptoms, markedly impaired quality of life, become less responsive to or intolerant to GDMT, and at high risk of recurrent hospitalization and death. So these are the real problem when you discuss about the advanced heart failure. I should mention one thing here. Our main objective of treating advanced heart failure is optimize GDMT therapy as much as possible. That is number one, although it is not easy to optimize. Second is the relief of symptoms, relief of these congestive symptoms. Maybe you'll have to change the diuretics or optimize the diuretic therapy, or maybe we'll have to add some inotropic therapy in this group of patients. In spite of this, some people may not be able to manage properly. So in this case, probably they need a lot of other helps, something like a multidisciplinary approach. So finally, I think that is our responsibility to help this group of patients with different care, starting from psychological counseling, in other helping in other ways. Okay. These are the two objectives, basically, to treat patients with advanced heart failure. So indicators of advanced heart failure, there's a repeated hospitalizations, need for intervention, inotropic support, and very high grade of symptom like NYHA class 3 or 4. Reduce exercise capacity, they even cannot walk even 300 meters. Intolerance to, again, AC inhibitors or RAS. Intolerance to beta blocker. And they need high dose of diuretic therapy, refractory clinical congestion, progressive deterioration of renal and hepatic function, worsening right heart failure or secondary hypertension, frequent hypotension, BP will be less than 90-80. Cardiac acacia, they develop persistent hyponatremia in the end stage. This is another problem. And refractory recurrent ventricular arrhythmias. If there is ICD, they need frequent ICD shock. And increased predicted warning mortality according to the kind of magic kind of scores, they have more score in this patient. And what the ESC definition of advanced heart failure, all these criteria must be present despite optimal guideline medical directed treatment. Number one is the severe and persistent symptoms of heart failure. And I say class 3 advanced or class 4. Severe cardiac dysfunction defined by more than or one of these 4. Number one, LVEF is less than 30. Isolated RV failure. Non-operable severe valve abnormalities. Non-operable severe congenital heart disease. And if EF is more than equal to 40, there should be elevated NP-proBNP or even a significant diastolic dysfunction. So these are the criteria to say patient is in advanced heart failure. And third is the hospitalization of unplanned visits in past 12 months for episodes of congestion requiring high dose of intravenous diuretics or diuretic combinations, low output requiring inotropes or vasoactive medications, and malignant arrhythmias. So these are the 3 causes for hospitalization. And fourth, severe impairment of exercise capacity with inability to exercise or low 6-minute walk test distance is less than 300 meters, or peak VO2 is less than 12 to 14 ml per kg per minute, estimated to be of cardiac origin. This can happen even other diseases like severe lung disease, renal disease, and others. So this according to health heart failure registry, this can be actually expressed in a mnemonic called I need help. I stands for inotropes, N stand for NYHA class or natriuretic peptide. E in organ dysfunction. Again, E is the ejection fraction less than 20. D is the defibrillator shock, recurrent appropriate shocks. H is the hospitalization, more than one episode of hospitalization in last 12 months. And E is the edema or escalating diuretics requiring persistent and having persistent fluid overload. And L is the low blood pressure, consistently low blood pressure less than 90. P is the prognostic medication or inability to continue disease. These are kind of parameters expressed by mnemonic I need help. And this explain, and this includes the actually advanced heart failure. Now, what is the aim of treating patients with advanced heart failure? We need to see first is whether we can improve the prognosis by treating with all these 4 drugs, 4 pillars of heart failure like ERNI, AC inhibitors, ARBs, MRAs, beta blockers, and SGLT2 inhibitors. These are the 4 pillars of heart failure. We need to start immediately. And of course, selected patient or device therapy, or in a very advanced heart failure, there are newer drugs like omecamtiv, mecarbil, and vericiguat. These drugs might help in very advanced heart failure, symptomatic heart failure. And second is we need to relieve the symptoms. In advanced heart failure, symptoms is very important. We need to emphasize on the symptoms of the patient. We need to relieve the symptoms of the patients. In a situation of hypoperfusion or end-organ dysfunction, sometimes they need inotropic agents. And in case of significant congestion, they might need loop diuretics, increased loop diuretics, or they might require injectable diuretics, or that can be combined with other diuretics. So these are the ways we'll have to improve the symptoms. In spite of the persistent symptoms or renal failure, probably ultrafiltration or maybe peritoneal dialysis is the one option which is more, kind of maybe is more comfortable for the patient, can be done at home. So these are the certain areas probably need to discuss. And finally, of course, in spite of whatever you do, there is some difficulties. This group of patients become very sick. And this is the stage where probably they need multidisciplinary palliative care, which really helps them in terms of their quality of life as well as their psychological background. Of course, very few patients in an advanced heart failure can go into heart transplant and this left ventricular assist device. Not all patients is suitable for this. So ultimately, if you really say the majority of the patient will need to continue GDMT therapy. So how to go ahead with this, this heart failure treatment? How to start with the GDMT therapy? So first, step one is they establish the diagnosis and start all drugs. The first, ERNI and heart failure, NYHA 2, 3, maybe ACE inhibitors in advanced heart failure, maybe ACE inhibitors is a little better option than ERNI, very advanced heart failure. Need to start beta blocker, MRA, SGLT2 inhibitor, as well as diuretics according to symptoms. Step two is that you will have to titrate these drugs as early as possible. If patient improves fine, we can follow up with this patient. So patient is not improving, maybe step three, we'll have to add other drugs. Certain scenarios, suppose patient is not tolerating ACE inhibitors, he can have some kind of hydrolyzing nitrate. Or patient is LV is less than 35 or less, and there is chance that patient can survive more than 1 year, maybe you can consider ICD. And if the ECG criteria fulfills, like sinus rhythm with QRS duration more than 150, these are the patients who is not kind of adequate with the GDMT therapy, not improved the adequate GDMT therapy. Maybe you'll have to consider device therapy like CRTD or so. In spite of that, suppose the patient develop refractory heart failure or stage D or what is called advanced heart failure, probably this is the time probably we need to think about the heart transplant or kind of other device therapy. So earlier you select this patient for the heart transplant LV device therapy, it is better. You should not get delayed in this. Of course, further after that, patient will, once advanced heart failure, we will need to continue GDMT therapy with many patients. So principle how to go ahead with the GDMT therapy is first step, it should be rapid. It should start early, kind of all 4 drugs. You may not have to start at a very high dose, maybe the small doses, we start with the 4 drugs, ERNI, beta blocker, MRA, SGLT2 inhibitors. And subsequently, within 4 to 6 weeks, you need to titrate the doses, try to achieve the kind of maximum tolerable doses or what is the recommended doses in 4 to 6 weeks. And in this case, probably you need to take help of various kind of other kind of situation, like you can control with the patients because they may not be able to come frequently to the hospital. I cannot call a patient every 4 weeks, every 2 weeks to come to the hospital. So this is the situation probably we can access the patient virtually or with a remote control. So these are the kind of devices or methodology can help in kind of linking with the patient and this monitoring the patient with kind of GDMT therapy. Of course, you need to check the regular laboratory parameters like kidney function, electrolytes, anti-proBNP. So that's how it helps in kind of titrating the doses. 5 core principles that avoid delays. That's very important. So as early as possible, within 4 to 6 weeks, try to optimize the drug and optimize the drugs and achieve the maximum doses. In-hospital titration is useful. It is more helpful because you can monitor the patient. If you get a chance to admit the patient or patient get admitted, probably you have to titrate the doses so that you can directly have evidence how he is tolerating the doses. Overcome the risk treatment paradox. Many times we feel that this is a very frail, older patients with comorbidities, they may not tolerate. It is not correct. Many times even old people, frail people, they tolerate the GDMT therapy. So I think that fear we need to overcome in these patients. And safety profile is always this drug is safe. Even in older age, frailty, and with comorbid condition, also these drugs are safe, provided you monitor the patient properly. Most important thing, you should understand that this GDMT therapy with optimal doses is very, very useful. If you omit that, you are subjecting the patient for further deterioration as well as death. So GDMT therapy is very essential. In spite of having advanced heart failure, we need to stick to the GDMT therapy as far as possible. Now, what are the strategies to manage GDMT in advanced heart failure? Yeah, there is some difficulty, no doubt about that. Due to the complex and fragile nature of advanced heart failure, several strategies are used to optimize GDMT and manage side effects. Number one, you need to have multidisciplinary care. It is not that I can take care of the patients, because as a cardiologist, you may not have a lot of time to afford one patient. So better to take help of the nurses and maybe pharmacists. So make a core group by which you can help with the patient in maintaining the GDMT therapy. There is one, multidisciplinary care. Second, the frequent monitoring. We need to monitor the blood pressure and renal parameters, heart rate, all these things, symptoms we need to monitor. Symptoms management over dose targets. So as I already mentioned, the symptoms are more important. Okay, fine, you may not be able to achieve the adequate dose, but with a minimum dose, but give more importance to the symptoms. Because these patients are very sick patients. So we need to give importance to the symptoms rather than keep on increasing the doses. This is very important. Management of hypotension. Sometimes these patients require titration of the medicine. You can reduce the drugs. Need not to stop the drug, but you can reduce the doses. Or maybe sometimes you need a hospitalization to optimize the doses. Consider advanced therapies. So this is a time where you need to consider advanced therapy like heart transplants or LVAD in these patients. And that has to be done earlier stages. Major issues of GDMT advanced heart failure is the intolerance and hypotension. This is and of course, renal dysfunction. These are the major problems. First, the intolerance and hypotension and the renal dysfunction. These are the major issues where we may not be able to maintain the doses. And how to do that, how to improve the tolerability. Number one, the initiation of low doses, a gradual build-up of the doses, up titration. Gradually you should do it. Suddenly you should not go to higher doses. Separating doses of each medication apart from each other. So instead of giving all medicine together or two medicine together, maybe you can different time of the day you can do that so that you can tolerate. Initiation of beta blocker after optimization of the decongestion. Initiation of MRA after SGLT2 inhibitor in patients with hyperkalemia. So start with the SGLT2 inhibitors. This helps in reducing the hyperkalemia as well as it helps in the renal function as well. So you can start MRA after that. This is one way to start MRA. Consideration of beta blockers after cardiac resynchronization. So patient is going for CRT or CP or D. Maybe you can increase the doses after that. That is also one way to enhance the beta blocker doses. Restart of medication after resolution of temporary contraindications. Strategies should be optimized, to optimize therapies because more complete therapies are associated with better outcomes. That is most important. AC and ERNI in advanced heart failure, it is very tricky because most of the people have some renal dysfunction and they will have hypotension. So many times they don't tolerate these drugs. However, we need to continue this drug because this is one of the major pillar of heart failure. And of course, you need to know that there is a subtle differences in the AC inhibitors as the ARB or ARNI in advanced heart failure. As you know, in paradigm heart failure, that class 4 symptom heart failure patients are less than 1%. So we know ARNI is better than AC inhibitor in that. But we do not know whether it is better in advanced heart failure. So similarly, many studies didn't include the very advanced heart failure group. So we are not very sure whether ERNI is very good in advanced heart failure. Again, live study have shown that ERNI is not as good as Belcertin. So it is not that we don't have actually a lot of clarity on this. In a sick group of patients in advanced heart failure, we should use the ERNI like in class 2 or 3 heart failure. So probably these studies need further clarification. However, at this stage, probably we need to think about that maybe AC inhibitors is a better option in advanced heart failure than ERNI. So maybe we can now consider AC inhibitors in this group of patients, build up the small doses, or start a small dose and go up. So this is one way, probably, kind of ACARB in heart failure. Advanced heart failure beta blocker, again, as I told you, it should be started gradually and reduce the congestive therapy, if the congestion, then go for beta blocker. And MRA, again, I told you, maybe the problem is that, kind of renal dysfunction and hyperkalemia. So better you start SGLT2 inhibitors first, then maybe you can monitor and start for MRA. SGLT2 inhibitor is a very, very useful drug, as has been shown in all stages of heart failure. It is more tolerable, it lowers BP, improves kidney functions. That's the reason probably it helps in starting MRA in this advanced heart failure group. Additional therapy like ivabradine, vericiguat, digoxin, and omecamtiv mecarbil, which is very useful new drug, and is basically inotropes in advanced heart failure, very advanced heart failure. Patient is very symptomatic, class 4, who has got a EF of less than 25. And these are a group of patients, probably it gives more benefit rather than in earlier heart failure. So this is one drug, probably can be considered in advanced heart failure. Of course, other device therapies are as indicated. In summary, I should say management of the heart failure, advanced heart failure is first the GDMT, try to optimize the GDMT therapy. If required, we can consider for the CRT, CRTD, or iron therapy, ivabradine according to the heart rate. If you cannot maintain or be hypotension, you can use this particular drug to maintain the heart rate, optimize the heart rate. If severe symptoms improve, then you can follow up. If not improved, then you can consider heart transplant or LV device therapy. You can to support these people. And in spite of that, there is no improvement. Then probably to improve symptoms, you can new option like omecamtiv mecarbil and vericiguat. These are the drugs can be used in this group of patients. Very advanced heart failure, symptomatic, not suitable for device therapy or heart transplant. To improve symptoms, again, inotropic agents, I should say maybe some inotropic agents are very, very useful. Levomethadone is very useful. And loop diuretics, maybe you can combine with other diuretics. Maybe you'll have to titrate the doses and increase the doses or IV. So these are the different kind of way you can help with this group of patients. If it's not sufficient, still you can go for ultrafiltration and peritoneal dialysis. In spite of that, patient not improving palliation is very important. In this case, probably you'll have to do the multidisciplinary palliative care. In conclusion, I should say that delicate journey or optimization of therapies in advanced heart failure is very critical. Even if the journey may be longer, maybe more tenuous, requiring repeated attempts for up titration and optimization of GDMT is very essential. Though intolerance to guideline-directed therapy is a feature of advanced failure, low dose, artful and slow titration and consideration of newer agents such as SGLT2 inhibitors may enable initiation of other agents such as MRAs, even at lower doses, and may increase the likelihood of tolerability in these patients. With these approaches, intolerance of GDMT may be less common feature of advanced heart failure. Thank you very much for time and attention.